did you do with this patient? So you have a patient who has, my SAT was 83%. I didn't look terrible. Clearly, I was uncomfortable. My blood pressure was a little on the low side. What do you do with this kind of patient? I mean, what I'm asking you is sort of very practical information and sort of what to do when a patient comes to your ED.
You know,
So this
I
is
would,
both for Nikhil and David.
Go ahead, David.
what I would say is, I would often get a call from my ED physician colleagues about appropriate triaging of these patients as to, because as we all encountered, the ICUs filled up very early, and it was a question of where are all these patients going to go? And so you don't only want to bring the sickest people into the ICU, and that pushed our floors to manage higher acuity patients than what they were comfortable with. But we wanted to be smart about it, as smart as possible. So the kind of questions I would ask the ED physician is, okay, so what kind of supplemental oxygen have you needed to use? They're just on a few liters nasal cannula. Their subjective dyspnea has, improved. You don't see accessory muscle use. Then that's probably a patient that you can send to the nursing floor. But if they're already on Airvo high flow or wall oxygen, and they seem like they're working pretty hard to breathe and not talking in full sentences, but their SATs are in like the high 80s, low 90s, that's the kind of patient that needs to come to the ICU. And maybe early on in the pandemic, that'd be a patient I would intubate up front. But now that's a patient that when I brought them into the ICU, I would just kind of leave them where they're at and see how well they would tolerate that kind of oxygen support. So it gets back to something that Keel had mentioned about getting back to basics and looking at the patient. I think more important than what an ABG or a pulse oximetry is going to tell you is, what is the patient's subjective dyspnea? What does their work of breathing look like? And I think regardless of the numbers, if the subjective dyspnea and work of breathing are reassuring, then you're probably okay where you're at with what you're doing. If the patient doesn't feel well, then obviously they need a higher level of care or more oxygen. So I think, triaging the patient from the ED was an educated guess at best, because I don't think any of us would be so bold to say we know who's going to do well and who's going to deteriorate over the next 24 to 72 hours. But I really felt that, getting a handle on where that patient was with what you were doing for them and how they felt with that intervention was a good measure for, what next steps should be.